And believe it or not, that actually is all that, in my mind, that you should really gain from this lecture. The 8 things that we've covered very relatively quickly. So again, let's review. First is, as primary care physicians, I hope you will really help your radiologists by being precise in your description of the patient's history, giving us the location of the fracture in a more precise manner. Don't just tell us patient has hand pain. Please tell us it's the third proximal phalanx. You now know how to name those bones and try to use that technique. Number 2, we've gone over the importance of the orthogonal imaging. 90 degrees, preferably. Whenever a patient has an abnormality of a joint, of a bone, do not use a single view to identify the abnormality. Get either a second 90-degree view or at least get an oblique view of that body part. This way you will not miss fractures as frequently. Number 3, the concept of avulsion has to do with the fact that, as we saw earlier, sometimes ligaments are actually stronger than the bone. In that case, the ligament stays intact and will pull a piece of bone off, resulting in the avulsion fracture. And we will see little bone fragments near the joint where the ligament is attached. Number 4, the so-called occult fractures of the wrist. When there is injury at the wrist, frequently we will not see it on the x-ray. So x-ray report will come back normal. Please do not rely on that normal x-ray report. If you think clinically based on your physical examination of the patient, and I hope you're still doing that physical examination, if you think based on that the patient has a fracture, even if the x-ray report is normal, don't stop there. Either get a repeat x-ray in 2 weeks, or if you have availability of MRI to your practice, you can get an MRI. Do not treat the patient only based on solely on an x-ray report. There are many bones in the wrist. There are 8 of them, and hopefully I've given you a dirty way of remembering what those 8 bones are. Number 6, the forearm as a donut. So the 2 bones in the forearm, the radius and ulna, are connected by very strong ligaments, basically forming an interconnection. So now we have a ring structure. Anytime there's a injury at one location of the ring, look for that second injury. It's usually there. It's actually more common to see 2 injuries than it is to see 1 injury at the forearm. Number 7, you've now learned how to identify the elbow joint effusion. It's not easy. You have to see many cases in your career, in your future training, to be able to find those anterior and posterior fat pads, these subtle black triangles. But every time you look at an elbow x-ray, look at that lateral view and look for those 2 fat pads. The more you see, the more you'll get used to looking for them, and then you'll be confident and comfortable looking for those signs of elbow joint effusion. The importance we discussed, if there is acute trauma and you see a joint effusion and yet you don't see a fracture, be careful. There probably is a fracture and you just don't see it on x-ray. All we see is the joint effusion. And finally, the so-called Hill-Sachs deformity occurs when there has been anterior dislocation of the humeral head with respect to the glenoid. And the glenoid is very strong. It causes a defect in the humeral head, which we now can see on x-ray, called the Hill-Sachs deformity, which can have clinical implications. Some surgeons may need to repair those depending on how big they are. So now you understand how they got there, because of that strong anterior glenoid. So we come to the end of our talk, and I thank you very much for your attention.